Today we are going to deal with a completely different problem, that is diplopia. Diplopia is not a very uncommon neurological problem. So let us see how we can approach a patient with diplopia. So diplopia means double image. The patient might say that the images are widely separated when they look to one side, and the images are clearer when they look to one side. So what is diplopia? How do you approach a patient with diplopia? First of all, diplopia can be monoocular, that is due to problems within the eye. It disappears when the involved eye is closed, or it could be binocular where both eyes are involved. Now, we are more worried about the binocular diplopia. Now, what are the common causes for a binocular diplopia? It could be lesions of the extraocular muscles, neuromuscular junction, or the oculomotor nerves. Rarely, supranuclear lesions can also produce diplopia by causing gaze palsies. Now, how do you differentiate supranuclear from a nuclear or an infranuclear cause for diplopia? Diplopia in both conditions will produce absent volitional eye movements. That is, wherever the diplopia is towards the side of diplopia, the volitional eye movements may be distracted nuclear, infranuclear, as well as supranuclear gaze pulses. But the reflex eye movements are preserved in supranuclear gaze pulses. For example, if you do a vestibulo-ocular reflex, the reflex eye movements are preserved if the cause is a supranuclear gaze palsy. Now coming to the nuclear causes, which is the oculomotor nucleus is the most common nucleus that may be involved, and the clinical picture would be bilateral ptosis. Why bilateral? Because of the involvement of levator palpebrae subnucleus, which is central, with unilateral third nerve palsy, and due to the involvement of third nerve there can be dilated pupil. You can have nuclear abducent lesions where there can be gaze palsy which produce diplopia with contralateral weakness or contralateral dysmetria. Now there is one entity known as internuclear ophthalmoplegia where it is due to the involvement of the MLF, where medial longitudinal fasciculus which connects the third nerve to the opposite sixth nerve nucleus. So lesions in MLF will produce impaired adduction, and the opposite eye, the abducting eye, there will be nystagmus. Now, if the MLF is involved along with pontine pyramidal reticular formation, which is involved in horizontal gaze movements, horizontal movements of one eye, you can get same side MLF and PPRF is involved. The horizontal movements of that eye, both horizontal movements are restricted, and in the opposite eye you only get abduction, which is abducting eye, which would have nystagmus. So that is 1.5 syndrome. The only movement would be abduction that is preserved. Now along with 7th and 1.5 you get what is known as 8.5 syndrome. So that is a pictorial representation of MLF and PPRF and how it controls the movements. Now infranuclear lesions could be due to third nerve fascicular involvement. Partial or complete third nerve is possible. In complete third nerve you get complete ptosis with pupillary dilatation, while partial you may not get a complete ptosis. Now what are the infranuclear third nerve? We have these named conditions: Claude's, Benedict's, Weber's, etc. Weber's is ipsilateral third nerve with contralateral hemiparesis, whereas Benedict's is ipsilateral third nerve with contralateral chorea, ethetosis or cerebellar ataxia due to involvement of red nucleus. Claude's is ipsilateral third nerve with contralateral ataxia, again due to the involvement of superior cerebellar peduncle. Now you can have an fascicular abducent nerve lesion like in Millard-Gubler, where you have ipsilateral sixth ipsilateral facial muscle and contralateral hemiplegia, or a Gradenigo syndrome where there is a clinical triad of otitis media, facial pain and abducent nerve palsy. Now after coming from the brainstem, where can the oculomotor nerves be involved to produce a diplopia? One of the most important sites is cavernous sinus, the lateral wall of cavernous sinus, where you have all the oculomotor nerves, the oculomotor trochlea, ophthalmic division and maxillary divisions of the trigeminal. All these are going through the lateral wall of cavernous sinus. So there you can get the involvement of third nerve, fourth nerve, fifth nerve, first and second divisions, and the sympathetics. That is, you can sometimes have Horner syndrome also. So that is due to involvement of lateral wall of cavernous sinus, where you get 3, 4, 5, 1 and 5, 2 involvement plus maybe Horner's. So that is the lateral wall of cavernous sinus. Now, after that, the nerves can be involved in the superior orbital fissure, where again you have 3, 4, and 6th involvement with first division of the trigeminal, 5, 1 alone. Ophthalmic alone is involved. Now, after that, you can sometimes get an orbital apex, the nerves can be involved, where along with the 3, 4, 6, and 5, 1, you can get second cranial nerve involvement also. That is how you differentiate the different areas where third nerve is involved. All these conditions, because the third, fourth, etc. are involved, the patient may have ptosis. So that is the orbital apex as well as the orbital fissure, where you get the 3, 4, 6, and 5 involvement. So that is again you can see the various nerves that are involved. Now coming after the nerve involvement, then comes the muscle disease. What are the diseases that can involve the muscle? It can be thyroid is the very common, where you can get exophthalmos or orbital edema along with maybe ptosis. It is the inferior recti that are most commonly affected, followed by medial recti, superior recti, and obliques. You can look for other signs of Graves' ophthalmopathy like lid lag, lid retraction, etc. will be there, and there can be orbital edema. Now, neuromuscular junction, the most important condition is myasthenia gravis, which ocular myasthenia, which is an important cause for ptosis. Can easily mimic a neurologic ptosis, but the diurnal variation will help you in the diagnosis, or the ptosis aggravates on after straining or after a prolonged upward gaze, etc. It is usually asymmetric ptosis which becomes enhanced on sustained up gaze. Now, there are two signs that you can look for in ocular myasthenia. That is, one is Cogan's lid twitch sign, where during refixation from down to primary gaze, the eyelids may bare the sclera transiently. And also the peak sign is in an attempt to forcefully close the eyes. It will not be possible because the oculi gets fatigued, resulting in the patient peeking through a partially opened palpable fissure. So that is the peak sign. So these might suggest that the patient is having ocular myasthenia. Now, how do you test for diplopia? Now, the diplopia could be tested. Horizontal diplopia is usually due to medial or lateral rectus involvement. If medial rectus is involved, the image separation is maximum for near vision. Diplopia occurs during near vision, and also image separation is maximum during near vision. And if lateral recti is involved, the diplopia may occur only during for distant vision, and also the image separation is maximum in distant vision. Now, in vertical diplopia, if the obliques or the superior and inferior recti are involved, you get vertical diplopia, that is image on one top of another. If it worsens on near vision, it seems that the obliques muscles are usually weak. So that is some clue towards the diagnosis of the muscle involved in diplopia. You can subjectively test, like in primary position, just see the patient and see which eye is higher. If the right eye is higher, what does that mean? Either the right depressors or left elevators are weak. Now, have the patient look to both sides. If the image appears farther apart on left lateral gaze, either left superior oblique or left lateral recti are weak. Now, have the patient look up and down towards the site where the image separation is maximum. If there is greater image separation on downward gaze, right superior oblique is weak. So, that is how you identify the muscle that is involved in diplopia. So, I think this has given you important information regarding diplopia in a nutshell. Please like and subscribe the channel and put your comments, questions in the comment box. Thank you.